So this is a 51 years old female, known case of diabetes, hypertension, now presented with the CAD ACS, evolved anterior wall ST elevation MI, and after 6 to 7 hours of chest pain, she presented to hospital, and this is the picture. This is a caudal view, and you could see you can see the LCX, and you cannot see the LED, and sort of thrombus you can see. So this patient don't have any LM left main. There is a separate origin of LED and LCX, and this catheter is in the LCX only, and you can see the shadow of LED in there in above the LCX. This is the shadow, thrombotic shadow. This is, and probably this LED is coming from this area, and this must be a LED, like it has to go like this. So this is a very complex procedure. So after all clearance, we took the patient. So this is a epicaudal view, and you can see the same thing. Must be a separate origin of LED, and this is the selective engagement into the LCX. This is caudal view, and you cannot see the LED because it was closed from the osteoprox, and it has a separate origin. There is no LM. There is the areocranial view, and there is no LED seen. This is LCX. This is RC and dominant normal. So this angio we have done with the radial, and then it was difficult to get access in such a separate origin of LED, and we don't know from where it is starting. So we changed the access to femoral, and this is the caudal view, and this was the XB catheter, and we tried to put the wire inside the LED, but you can see there is a separate origin of the LED. There is no LM, and then wire used to go in L6 only. So we changed the catheter from XB to JL. With a much difficulty, we progressed the wire into the LED with the adjustment of the catheter. And this is the areocaudal view, and you could see the wire is in the LED, and LED has opened up after giving some tirofibin intracoronary. The epicranial view, and you could see the same thing. Wire is in the LED, which has a separate origin. You could see, but this patient is a long-standing diabetic, and you could see the distal LED is very thinned out. The same thing you can see here. Thrombus is there in the LED everywhere. So we decided to put one small diameter stent, 2.5, just in distal part, because mid part, because distal part is very thinned out as the patient is a diabetic. So this was the 2.5 into 20 stent in this mid part of LED where the thrombus is there. So we wanted to plaster the thrombus along the vessel wall, and this is the stent placement. There is a stent deployment in the mid part of LED, and this is the picture after the stent deployment in the mid LED, and then we plan to put one more stent from the ostium of the LED to this and to overlap the stent. This is the caudal view, and we wanted to deploy the stent from ostium of the LED to mid LED, and then we will overlap. It was a difficult task, and because we don't know the exact origin of this LED, so this is the scene in all view we have taken, but only the appropriate view to deploy the stent is the caudal view, so that we can see the ostium of the LED. This is the caudal view. You cannot see because the L6 is overlapping over there because it has a separate origin. So this is again the placement of stent in caudal view. Again, we did the placement of the stent from the ostium, and we deployed the stent here. And this is a picture after the deployment of stent, and then we have done the overlapping with the mid LED stent. And this was the overlapping of the stent. And this is a picture after the stent deployment from ostium, and you could see mild haziness in the ostium again. So we have given tirofibin and everything. It was very difficult. Meanwhile, patient BP drop. Patient had one episode of VT, and then, but anyhow, we opened the LED now, and BP is coming up now. So after giving tirafibin nicoran, you could see the LED has completely opened up. Distally, the LED is very thinned out. So this is the ileocaudal view, and you could see how LED has opened up, which has a separate origin, and it was anomalous. Even it has a separate origin, but there was the anomalous course of the LED right from the ostium. It was very difficult to put a stent over there. So you could see the same view, ileocaudal view, and we have opened the LED now. This was the angioplasty to LED, primary angioplasty after 6 to 7 hours of a chest pain, and patient had one episode of VT and then hypotension. But now after opening artery, it has improved. The BP has come up, and now patient is stable. So this was the complex primary angioplasty with separate origin of LAD and LCX. There was no LM left main. So this was a very challenging case. In such cases, we need to use the good catheter. First of all, we have taken the XB catheter, but we could not. It was like the catheter used to go in LCX only. So we changed the catheter to JL3 because this was a female patient, and JL3 into 6 French we have taken, and it was engaged. And then we could do the procedure. Very difficult to pass the wire. This was sort of organized thrombus. This wire was a BMW PTCA wire. So this was the complex primary angioplasty to separate origin LAD, which was occluded right from the ostium